context in which we're going to think about, the interventions that we're going to talk about today. Now, we know very well what happens to a brain that is deprived of sound. And this is some beautiful data from a study in the early 2000s. And it's an old slide, and I continue to show it. And what you can see here is these areas of blue in the brain. And blue indicates essentially the brain doing nothing. And that's what happens in the initial setting of deafness. And what you can see here, these are actually two individuals, not a typo. They're both 6.5 years duration of deafness, but as the duration of deafness increases, what we can see is that there's less blue. There's less of the brain doing nothing, because at the end of the day, the brain doesn't like to do nothing. And for many, many hundreds of years, thousands of years prior to having cochlear implants, if you lost hearing, it wasn't coming back. And so the brain has developed evolutionary processes to manage this and remain efficient. And so it's not surprising that, again, left in silence, the brain is going to pick it up and go do something else. And these are the changes that we're trying to prevent in children. And the way we do that is by intervening as early as possible. Now, when we think about sensitive periods for intervention, I think that's something that we all understand, that there are these windows, and that last slide really does emphasize that. But I think as surgeons in particular, with our concrete nature, this is how we think about it. If I just do X, whether X is put in a cochlear implant, whether it's get amplification on the child, if I just do it by X number of months, years, then we're good, right? We think about the 1-3-6 model, and we use it a little bit as a check mark, but we know that development is not flat until that certain point in time. It's a complete false perception that's probably constructed by our human brains. I know it is. And the reason that we know that is because the time period continues to change. So when Dr. Slattery started, again, it was a time where we were probably happy to get an implant in by 3 years of age, right? That was considered success. And 3 years turned into 24 months, and 24 months turned into 12 months, and 12 months is now turning into 9 months or 6 months. And so it tells you that this is an inaccurate reflection of how development actually happens. It is not a flat line. It is a slope. And every day with hearing loss is not a good day for the brain. And really, that's how we should think about it. And we have extremely strong evidence to suggest that that's the case. And probably some of the best data out there is coming out of the Lochi study from Australia. And every time these individuals present at a conference that I'm at, I make sure I attend, because there's much more insight that you can see in their presentations that is not yet out in the literature. And, I have to commend these individuals for being so ambitious. I'm a practical human. And, oftentimes when I think about research, I think about what's doable. And these individuals did what is pretty impressive. They engaged on a journey that's going to last people's, careers and even beyond their individual careers. And they looked at almost 500 children, most of whom, 60%, received implants younger than 12 months of age. That in and of itself is a feat. And they continue to follow these kids along to see how do the delays inherent to any period of deprivation continue to work out in the wash as kids get older. And I'll highlight point number 2 here, which was in a lecture that they gave at the European CI conference last year, in 2023. And what they were finding at that point is that the delays that kids had at 3 persisted at 9 years of age. They were out, that's how far out they are, is 9 years from the initial cohort. And I would hazard to say that what's present at 9 is going to be present at 15, is going to be present at 25, is going to be present at 75. And so it really behooves us to think about ways in which we can get those implants in or the hearing aids on as early as possible to minimize their delay, because there is no period of deprivation that doesn't come with consequence. Any day with deafness is not a good day for the brain. So I'm going to bring you into our program. And this is our program since its inception in the late 80s. And one of the things that we've been able to look at over time is, the proportion of children who are implanted in this younger age group, less than 1 in red and now less than 9 months. And you can see these are small proportions based on the whole, and you can sort of see the trajectory that I talked about, right? Back in the 90s, we were happy if we got the implant in, under 4 years of age. And now, again, we're unhappy if we don't get it in early. And we could celebrate these kids who end up in here, and I could tell you how we do it. But that, is probably not nearly as important as reflecting on the children who are in these groups who should have been implanted under 1 or under 9 months of age. Now, many of these kids who are in this yellow, teal, and royal blue bar need to be there. They have progressive losses, they have acquired losses, but many of them, I can tell you, should have been in the group that's red and purple, the under 1. And we're going to really focus on, as I'll share with you how we focused on that as a program in order to see where are we inefficient, where are we not, meeting families where they need us to be. So this is the data. And so let me walk you through this because there's a lot of information here, but I just want you to see the pattern. What we've listed here on the y-axis is all the things that need to happen generally for a child to get a cochlear implant in our program. And the first thing you can see is that there's lots of steps for these families. There's lots of hoops to jump through. And then what these 3 boxes are is this upper box is when things go well. So these are the kids who got implanted under 12 months of age. In the second box, these are the kids who were implanted under 2. And in this third box, these are the kids who were implanted between 24 and 36 months. So we're not even going into that greater than 4 years of age. And what you can see is, other than that, there's lots of things these families need to do, is that the spread increases. But it is all anchored on a single point, and that is the confirmation of the sensory neural hearing loss. And that makes so much sense. Once these kids are in our program, we're really good at moving them through. I am sure in your program, you are really good at moving them through. But the challenge is when the children don't get there when they should, when there's delays prior to the confirmation of hearing loss diagnosis and the recognition that this child needs hearing aids or something more in the form of a cochlear implant. And we dissected each of these data points and each of these children, and we looked at what were the reasons for delay. And many of these, I think, will be familiar to you. I'm sure they happen in your program as well. Sometimes it's a lack of screening, and we'll talk about what happened in Ontario during COVID. Sometimes children pass their screening, and we don't have a school screening system that is universal in Ontario. And so you have to wait for, signs or the child's capacity to report. We also see lots of immigration to Canada. And so many times, even though families might have known about the hearing loss, they lived in a place where they didn't have the privilege and means to do it. There can also be, inconsistencies in testing, additional comorbidities. There's children, particularly in this other group, that had other surgical issues. These are our NICU babies that end up into this group. And then there's these last 2 categories, the delayed follow-up and the loss to follow-up. And we talk about these families every week. These are the families that show up on our CI meeting agenda. We have a section called Patient Challenges. And we talk often about families that are really, for any number of reasons, unable to come. And I'm going to share with you a little anecdotal story because I think that, personally, I would often pass judgment. Oh, gosh, why don't there no-shows again? They didn't come to their clinic appointment and all of that. And I remember thinking that once I was in a clinic, and you know what it's like, right? When you see patients haven't shown and you're like, oh, are they going to show, or are they just going to be super late and sort of mess up the rest of my day? That was my mindset in that moment. And I saw that, again, a patient who was supposed to be there an hour earlier had just checked in. And I was like, oh, like, seriously, I'm going to run late for the rest of the day. And then around the corner comes this mom with a child who had multiple exceptionalities in a wheelchair, CP, nonverbal. And in that moment, I said, Sharon, you're an asshole. Okay. And it really stuck with me that, I struggle to get my developmentally typical 10-year-old out the door if we've got to get to hockey. This poor mom is trying to get her child who's got a ton of exceptionalities, who's wheelchair bound, who's nonverbal, who has to require public transport to get to my clinic. Of course, she's going to be late. And that changed my sort of perception about how I think about individuals who don't show up to our clinic. And so instead of judging, and I still judge sometimes, we're all human, but I try and approach it with a degree of curiosity about what's making it hard for them and how can we make it easier. And, we talk a lot at Sick Kids about precision medicine, right? And I think we often think this to mean, molecular genetics and all of that. And we're going to talk about all that great stuff. But it also is about thinking about it on a socioeconomic status and how do we reach families where they need us to reach them. Many of these families are struggling. They're on a bus to go to the food bank, despite the fact that we have a pretty good a social net here in Canada. There's still a ton of struggles. And this here is what we're asking them to do, to come to all these appointments. And so how can we do it better to provide a system that meets them where they need us to? And so that was my little, revelation and how I think about when we talk about delays to follow up and loss to follow up. So, and just to give you a little bit of a zoomed in approach, this is again the scenarios where things are less than ideal, where we're getting the implant in between 24 and 36 months. And you can just see again, there's lots of things on here, other surgeries. A lot of these children had other surgeries. But again, what we see, this is the hearing loss confirmation, which often comes a little later in these kids. And then we see that that's really the thing that pushes them into receiving intervention. Now, I've also changed how I think about etiology over the 15 years of my practice since I finished my fellowship. And I think that, oftentimes as surgeons, I've certainly heard myself say, I've heard my colleagues say, well, if it's not going to change what I do, then why does it matter, right? And I think, again, there's value and truth in that comment from the lens of a surgeon. But I think there's also value that we don't see as surgeon that comes from the lens of the family. And I've sort of separated out those things here. And I've always been a little bit amazed at the relief that can be seen on a family's face when they finally find out why their child is deaf. And, I've had occasions where children are 14 or 15 and they come back for some reason to the clinic after receiving their CI to see, either Blake Papson or myself, and we review their etiologic workup that was now, 14 or 15 years old, and we come up with a diagnosis where we didn't have one. And even if it doesn't change anything, there's huge impacts for families. Oftentimes moms have blamed themselves for whatever they did or didn't do during pregnancy. And so a genetic diagnosis takes that burden off, even 15 years later. Families also report a huge sense of empowerment and capacity to connect with others who are walking the same path. And so not just children with hearing loss, but rather children with hearing loss from Connexin 26 or probably more impactfully Ushers. And so again, I think it's important that we adopt both our surgical, our clinician lens, but also understand that there's meaning beyond what it changes in terms of our management plan. So what I want to delve into is, can knowing the etiology actually impact the quality with which we deliver care, particularly as it relates to timelines to intervention? Because this is, I think, something that we don't necessarily, it wasn't on that last slide in terms of getting to where we need to go in terms of these children's interventions. So what we can see is, and this is some of Elliot Shearer's data, who has some of the most beautiful data on genetics. This is sort of the breakdown of causes of congenital hearing loss, and it reflects the tools that we have in our toolbox. We've got genetic evaluation, we have imaging, and we have capacity to test for cytomegalovirus. And we're going to touch on all three of those, again, from the efficiency lens. Now, this is all comers. And, what's important when we look at etiologies or breakdowns of etiologies for hearing loss is understanding who's in the denominator, because it can vastly change what we see. So this is a group of kids who have severe to profound hearing loss. And one of the impressive things, and this has certainly changed over the course of my career, is the frequency with which we're able to provide parents with an etiologic diagnosis, 75% of the time. That's impressive. And it continues to increase. And I'm not sure that it's as good in my clinic as it might be in this study, but it's certainly telling us that we're able to let more families know why their child has hearing loss than we ever were before. So what we're going to do is we're going to walk through each of these sort of tools in our toolbox. That's how I present it to families, and talk about how they might intervene and what's new and upcoming. So we'll start with genetic testing, which is by far and away in pediatric hearing loss the most efficacious tool in terms of diagnosing etiology. So it's complicated. And I've certainly learned more and more, and I have our genetic counselor on speed dial because I still have lots to learn. But I think it's very important for us as otolaryngologists to continue to develop a working knowledge of genetics, because we are often the first people that children with hearing loss see. And I understand access to geneticists in the US is similar to Canada, that it can take quite a while and there can be significant delay. And one of the take-home messages is that the early we know the etiology has a huge impact on how we deliver care within the time frame that minimizes developmental delay. Now, one of the things that makes genetics so complicated in hearing loss is that it is highly variable. There's a huge amount of genetic heterogeneity compared to if we had a similar pie chart for cystic fibrosis, for example, where again, most of the disease is caused by a relatively few mutations, whereas there's some big players in hearing loss, but then there's lots of little players. And there's lots we also don't currently understand in terms of genetic etiologies. And that's what makes it so complicated and in many ways a little onerous to get our heads around. In terms of, again, this is a different denominator. So these are children who are receiving CI, so generally severe to profound. And so again, the variability reduces, which is great, especially as we focus on those. And the large pieces of the pie do change. But even in the setting of a pretty homogeneous group in terms of phenotype, there's still huge variability, and their diagnostic rate is almost 50%, which is incredible. Our diagnostic rate in Ontario, the last time we measured it, is 15. And so we're still working on why we have that gap. It may be a reflection of diversity. It may be a reflection of the genes included in our panel. But I put that out there because this is hard to get a diagnostic rate of 50%. And it's reasonable to still do it even when you're getting a diagnostic rate of 15. So in terms of the probability of having a genetic etiology, and I think this is something that many of us, understand in our counseling, I'm much more likely to order genetic evaluation in a child who's got bilateral hearing loss. I don't tend to vary too much between symmetric and asymmetric, but I do order it less and in a different algorithm in our kids who have unilateral hearing loss. And you can see that, again, the bilateral symmetric child is much more likely to have a genetic etiology. And so I think factoring these things in as you navigate these questions with parents can be really helpful. The interesting thing about the unilaterals, and they're going to come back throughout the talk because I think it's a small but particularly interesting group, is that when you think about those kids with unilateral hearing loss who do have a genetic diagnosis, and so it should be part of the algorithm, but maybe not the first step, you're much more likely to get a syndromic diagnosis. And again, some of these kids will have a marker of cochleovestibular anomalies or abnormalities of the cochlear nerve, but that can be part of a bigger syndrome, Wartenberg being one of the most common ones. All right. Now let's talk about, I touched briefly on the fact that we're a pretty diverse population here in Toronto. And so in terms of your probability of making a genetic diagnosis, it varies by ethnicity, partly because not because genetic causes are any less common in certain populations, but we know more about them in specific populations where they've been well studied. And so we're much more likely to get a genetic diagnosis, or at least one with some degree of certainty in children who are Asian or white versus individuals who are Hispanic or Black. And that highlights the need to do better studies. And again, I think this is something where we're really well poised to do this in Toronto. I was in clinic on Tuesday and I had in my clinic 5 separate different language interpreters. And so we have an immense amount of diversity where we can try and close this gap in knowledge, so that we can make genetic evaluation more equitable, because what we know is different and also who gets offered genetic evaluation is different. All right. So I said we'd come back to COVID. And so newborn hearing screening is amazing. It's done a beautiful job of helping us reduce the delay in diagnosis. It's taken us from, recognizing that children have bilateral profound hearing loss at 2 years of age to knowing they have it at 1 month of age. The tricky part is all of our programs are far from perfect. They're far from perfect in terms of how the initial test is offered, when, where, and they are particularly imperfect when it comes to follow-up. I saw a little girl born in Ontario just prior to the pandemic who failed her newborn hearing screen. And then the family, while they got offered an ABR, they didn't go because it was right in the heat of COVID. And now she is 5 and has no language. And it's heartbreaking because this goes back to we can blame the family for not following up, but we can also blame an imperfect system for saying, like, how come we didn't know to call them more, right? How come, we didn't reach out to their family physician? Because this child's brain and the developmental trajectory of the brain as a result of that loss to follow-up is going to have huge impacts on where this child can be and the potential dependency that she's going to have, because she has absolutely no language. She does not have sign, and she's 5. And so one of the things, again, that happened is the Ontario government deemed newborn screening, hearing screening, a non-essential service for a good proportion of the pandemic. And so certainly we have a cohort of babies, her being one of them, who are either not screened or not followed in an appropriate way. And so with this in mind, one of the initiatives that began actually prior to COVID it launched in 2019, but we began thinking about this about 4 years earlier, was how do we make our screening program for permanent hearing loss in Ontario better? And one of the things that we elected to think about was to couple the physiologic screening with risk factor screening. And that was really, I think, why the government said yes to increasing the funding for this program. And we instituted 2 things, and I'm going to bring you through both of them. And the first is a universal genetic screen, and the second is universal newborn CMV screening. And so this is every baby born. It's not targeted screening for kids who fail their newborn. It is every baby born. So let me show you sort of our 4 and 5 year data that's recently been published. So this is just a snapshot of Ontario. So we have about 140,000 babies born. So you can do a comparison to the region that you're in. And when it came to genetic risk factors, and I'll get in more detail which risk factors we selected and why. Essentially, this was going to generate about 100 positive genetic babies with genetic risk factors. So let me walk you through the data. So we decided to start off, we had to start small, because even though small is imperfect, small is still starting. And if we'd bitten off more than we can chew, we would have failed. And so we decided to start with highly penetrant mutations in GJB2, and a few mutations in SLC26A4. And those were chosen partly because of the progressive nature. So the idea was, again, that we would capture children who were normal, at least from the SLC26A4 perspective at birth, who were then going to go on to progress. It was a lot easier to select the mutations for GJB2 than it was for SLC26A4, but we started somewhere and we continue to measure and modify. Again, I put this up here only to say that the hardest part of initiating this program, other than convincing the government, was to create a pathway. Because just like hearing screening, what happens when you have a positive? Who's going to call the family? What are they going to say to the family? What's going to happen next? Who's going to refer to the otolaryngologist? And we've seen many screening programs fall apart when the horse gets put before the cart, where all that is planned is the point of care test, but not the what's going to happen next. And that's what took, the 4 years between funding and actual launching of the program. And I think we did this really, really well. And part of our capacity to do it well is that we chose a small number of genes. We did not open a huge degree of floodgates. And so this is our published data. It's now actually been accepted to genetics in medicine. And again, we identified a small number of children, most of whom referred on their newborn hearing screening, which was the expectation, particularly with the kids with GJB2. But you can see some that passed and a good number, again, that missed their newborn screening. And there was a couple of reasons for this. One was COVID. And this is a consented process. And so what happens is that they present for their hearing screening, and despite the fact the sample's already been collected and tested, the family has to consent for release of those results. And so many times, what happened, particularly in COVID, we actually lifted the consenting process because the hearing screening wasn't happening regularly. And so many of these kids got their genetic diagnosis before having a screen, and they went right on to diagnostic testing. We have since reinstated the consenting process. And at first I was like, why? It's going to take these babies longer to get to me. But the rationale is that it's actually going to be our ability to monitor our newborn hearing screening program. And so right now, we don't know who misses their newborn hearing screen. There's no comparison of birth registry to newborn screening results. And so this is going to provide a link between those two programs, because we're going to be sitting there with a dry blood spot and a result. And if we don't have consent, we have to assume that that baby never got their hearing screen, because you have to send the consent form either way. And so it's going to provide a check and balance in that imperfect system to make sure that we call that family and figure out how do we get that baby tested. And the other part is consent gives us a proxy for acceptability. And if you look at this consent rate, this was prior to COVID, it was almost 99%. So no family minded having genetic screening for hearing loss risk factors whatsoever, or CMV screening. And so it tells us that this program is highly acceptable. And I think that that's important, because I think many of us might assume that this would not be acceptable to many families, but it is absolutely acceptable. So what's the added value? Initially when we started talking about this, I was a little bit of the negative Nelly at the table saying, well, we're picking these babies up anyways with newborn screening, especially our kids with, 35 del G mutations that are homozygous, right? Like, why are we doing extra work? And so one of the things that we did is we went back and looked at a retrospective cohort of about 500 kids in our hearing loss program who had had genetic testing. And we looked to see, the goal was to see who would have been benefited from this added test. So let me take you through that data. So these are all of the variants that we found in our hearing loss population, and the ones in red are the ones that we pick up on screening. So not all of them. And this is the cohort of children in that period of time, just under 500 kids who had been identified as either having GGB2 related hearing loss or SLC26A4. And so then what we did is we looked at who passed or who referred on their newborn screen. Okay. And so, many of them did not have a screen or they passed. Okay. So here's the cohort that passed their hearing screen. And it was a little shocking to me to think about a child who had homozygosity for 35 del G that they would actually pass their hearing screen. And in terms of the ones, we did not have screening data for any number of reasons. They missed the screen. They immigrated from a country that didn't have screening. This is what happens when we use genetic and hearing screening risk factors, is that we double identify a lot of kids, but then we also identify kids who pass their newborn hearing screening. And I think that is immensely impactful. Now, let's talk about the impact on timeline, because I was still a little bit of a naysayer, for all those individuals in green who then got twice identified. And so we had an impression, because many of these families were in our offices amplified, certainly prior to 3 months of age. And they're like, okay, when are we going to put implants in? And so they were pushing us as a team and as surgeons to think about, when should we put implants in these children who have both a physiologic and an etiologic diagnosis? And so we compared two groups of children, all of whom had been subjected to screening, so same time period. And these were babies who had profound deafness bilaterally, who went on to bilateral implant. And we had a group that had a positive etiologic screen versus a negative etiologic screen. And this is what we saw. We pulled a few of the timestamps towards CI. And what we can see is that everything happened earlier for those with an etiologic positive screen. And the reason for that is that there's a big wait, not a wait list, but there's a list of individuals who need diagnostic testing after having referred. And only one in 10 to 15 children who refer on their newborn hearing screen are actually going to have permanent hearing loss. And what happens is that when you have a positive etiologic screen is someone picks up the phone and gets that child with risk factors to the front of the line, as they should be. And so everything fell into line. And I'll point out again here, we were quicker at getting MRI under 6 months, and this had a huge impact on how we work children up, and I'll share that with you next. Before I do that, though, this is some data from Dylan Chan's group, and it also demonstrates that families are more likely to be receptive to hearing rehabilitation amplification CIs. The only variable that makes a difference is a genetic diagnosis. And so we've all experienced sort of the incredulity that families may have with some of the testing and the fact that their child has hearing loss. But you give them that physiologic data and amplify it with an etiologic cause, and it is way more impactful and gets them through what they need to get through in order to get the job done and get hearing aids on that child. The other good reason for it is we've got genetic therapies. And so you can only know who's going to qualify for a study if you know their underlying cause. And that's a relatively small select group of individuals with otoferlin in this moment. But there are many other targets people are working on. And so I think becoming adept with genetic ordering and some degree of genetic counseling as an otolaryngologist is going to be one of the necessary things as we move towards more genetic therapy options. All right. Now we're going to move into CT MRI. And one of the things that I'm going to chat with you about is something that we noticed from our data. And so what we were seeing here is that we were getting MR and CT, often in a single session under anesthesia. And what you can see is that these kids had their MR, their CT, and that's when they had their implant, like not very long later. It was often the holdup to getting the kid into the operating room. We'd had a surgical date saved and we were desperately trying to get the imaging prior to that. And so we first went to a system where we dropped the CT in many cases. And, again, I was reluctant. I was at the beginning of my career when we did this, and I love a CT scan in terms of surgical navigation. But over time, I've become better and better at reading MRs and realizing that everything I need is there. And that's, first of all, simplified the approach for many kids. Now, we still do get CT in about 10% of kids, and there's certain reasons or indications that we do. Certainly, immediately, if there's meningitis, although I have to say I'm going more off MR more and more in these kids, temporal bone trauma, or anything that could lead to ossification. And then subsequent scans in kids who are found to have very anomalous cochlea. So not IP2s, IP1s, IP3s, or syndromes such as branchiotorenal and charge, where the approach shot is often going to be difficult, and having that bony anatomy is a little bit more helpful in terms of knowing what you're going to encounter. Now, we were trying to do feed and sleep MRI, and our technologists hated it because it's labor intensive and it's tricky, and there's a whole lot of hope that's and disappointment that can happen, and they didn't think they were very good at it. So we said, give us the data. Give us your data on feed and sleep MRs, and we'll tell you how good you are. And so one of our fellows put this together, Sam Go, and what we found is that they're exceptional at it. They were able to get a diagnostic scan in 88% of kids, particularly if they were under 6 months of age. And so this really changed how they felt about it and how they felt about the effort. And we are becoming more and more successful at doing this, especially now that babies are getting to me within a huge amount of time frame that allows me to order a feed and sleep scan. All right, the final chapter, okay, and that is about CMV. And I've put that in other tests. So let's take a little journey. Now, CMV is tricky. It's super, super common, but it creates immense sensory deficits that are often compounded by central disease, but it's hard to diagnose because you need to have a sample from the period of time when the child was in or just out of utero, okay? It also causes progressive disease, so many of these kids are going to not be identified through newborn hearing screening. It's also treatable, and, we think of antivirals in that scenario, but I also think of early hearing intervention as probably being the most important treatment component of CMV. We know that this CMV loves the cochlea, and so what we can see here these are scanning electron micrographs of the stria vascularis in a normal mouse model, and then this is a mouse model that's been infected with CMV. I often will talk about vestibular function. This is my only nod to it in the talk, but I think it's super important that we measure vestibular function in our kids with hearing loss. And CMV loves the vestibular system even more than the auditory system. And so we really need to look for deficits in these children because it can have huge developmental impact. Now, as we talked about, you need a sample taken from early in life. So you need to have suspicion or test early, or you need to have access to your dry blood spots. I don't know how long they keep them in California, but they keep them forever in Ontario, or at least they have up until now. So knowing that can give you access to that, not to make a diagnosis in a time frame that allows you to think about antivirals, but in a time frame that allows you to give families that etiologic information that's so important. There are many times where we don't have any of this information, but all we have is an MR that's got temporal lobe cysts or even non-specific white matter changes. And again, this will be, for the most part, related to congenital CMV. And so we often make the presumptive diagnosis off of imaging findings alone. Now, what happens to hearing loss in the setting of CMV is that it rapidly progresses. And so what you can see is that this is the survival curve of hearing in a group of individuals who were born with congenital CMV. And the red is a non-CMV control cohort. And what you can see is this survival curve within the first year of life is steep, and that's why children get missed. And then oftentimes we don't pick them up until there's a school screening or they wear a pair of headphones, for example. We decided to look at the evolution of hearing loss because we had a huge group of children that we had tested for retrospectively for CMV. And in that group of just over 1,100 children, we found 11% were positive for CMV. And most of them had newborn hearing screening. So we were able to look at, how good was it and how many of them passed. So what we saw is that lots of ears passed their newborn hearing screen. And when we think about the age at diagnosis being 4 in those kids, that's not the age of onset. That's the age of diagnosis. They probably lost their hearing in that first year of life, but we didn't know to have them on our radar. If we think of ears, all the ears that passed, this is individual ears, what we see is 50% of them went on to develop hearing loss. By 5 years of age. And again, all of these kids had hearing loss. So it is a biased cohort, but it gives you a sense of what happens when children are going to develop hearing loss from CMV. Now, I care more if you passed in both your ears, because if you passed only in one, then you're still probably in the system. But this is what happens when you pass in both ears. And again, 50% of these children had hearing loss detected at 3.5 and 70% by 7. And so there's absolutely delays in diagnosis and intervention built into the disability caused by congenital CMV. So in comes universal screening, because that's really the only way to get around it. And it has now become the most common thing that we screen for in Ontario. Again, there is a huge clinical care pathway associated with it that continues to evolve. And one of the ways it's evolved is that, our ophthalmologists here at Sick Kids were sick of seeing these patients because they were always normal. And so we encouraged them to look and publish their data, which they're in the midst of. And we've now dropped the ophthalmologic assessment, except for a very narrow group of individuals. So let's look at our outcomes. We identified a handful of kids with hearing loss at birth, but then a huge cohort of children who are then going to need to be surveilled, right? And the interesting data is going to come from that group. This is how we surveil them. And so it was important that we build in a framework that was actually doable within the confines and finances of our infant hearing program. So this is what we've used for children who do not have hearing loss, but continue to need ongoing assessment. And we continue to use the data to refine this process. Many of them got treated, the vast majority who had sensory neural hearing loss at birth. And many of them had unilateral. And this is going to be the final portion of the talk before I conclude, because I'm going to take a little off-road here, because we know that there's a high prevalence of unilateral hearing loss in the setting of CMV. And we also know that there's tons of consequences for unilateral hearing loss. And so when we look at the cohort of kids that we've implanted at Sick Kids, what we see is that there are children with CMV highlighted here in red that factor into each of these categories: congenital, early, and late onset hearing loss. So CMV is very, very common in this population. I want to show you this slide just because it also highlights what we've learned about unilateral hearing loss. This is from the 90s. And so what we can see is that there was a huge amount of unknown. We now know who these kids are. We've got our kids with symptomatic CMV that we've always known about, but this 60% unknown is either absent cochlear nerve and asymptomatic congenital CMV. And so it's a reflection of how, when we change what we do or offer families, such as cochlear implant for single-sided deafness, we alter what we know about the underlying pathophysiology and characteristics of the population. So what you can see here is I've broken down, again, just how common CMV is in our children who get referred for single-sided deafness intervention and those who ultimately go on to receive it. The important point in this slide is that 83% of families say yes to an implant. And that's on a background of about a third of families feeling that an implant for SSD is actually what they want to do. It's not hugely acceptable to many, many Canadian families. And I want to highlight the reason that's the case. And it's partly how I counsel patients. And so this is the same data from my trio thesis, where in that group of 117 kids, 41 of them had single-sided deafness and a normal hearing ear, or developed single-sided deafness very quickly. And we had followed them over the course of time and were able to see what happened to the other ear. over time, and 65% of them developed bilateral hearing loss. And that's the data that speaks to us about how we talk about implant in these kids, because to me, an implant in a child with single-sided deafness from CMV is the first stage to maintaining a binaural, or not binaural, bilateral system, and a brain that hears bilaterally over the course of a lifetime. And so this is the data we share with families. The final step in terms of the efficiencies that this develops for our program, this is the same thing we did with genetics, but for single-sided deafness. So negative etiologic screen and positive etiologic screen, and everything happened quicker, including implantation for these kids. So, the question is, can we actually fix this with an implant, which is a talk for another day. But I couldn't help but include a slide of some of the data that we have written up based on this cohort of 71 children with very limited duration of deafness. And the take-home message is, it helps, but only if they wear it. Okay, and I think we've seen that across a few programs as well. So in summary, we've got work to do to get more of these kids who should be in this red and purple bar portion of the bar. And we continue to endeavor to do that on a daily basis. And so, what I'll say in summary is that I think early identification remains the foundation, and you can factor in etiology as a way to increase the efficacy of your newborn hearing screening. In addition, we are going to learn so much as the algorithm evolves. It looks different today than it did when I finished fellowship. It looks different today to Dr. Slattery than it did when he started. And it's also important to look at your programmatic efficiencies and inefficiencies, because I think if you measure these, it can be very powerful data. So I will finish there.